You have to give me permission to record.
All right. Welcome, everyone. My name is Kian Wong. I'll be co-hosting tonight along with Dr. Simon Wong from Melbourne, Australia. Well, you may have been getting some emails from me. I'm helping my brother with all the marketing and email correspondence and so on and so forth. So it gives me great pleasure tonight to introduce to you not only Dr. Simon Wong, but also a very special guest presenter, Professor Narinder Singh from Sydney, who will be presenting on a dentist's guide to nasal obstruction in children. So welcome from everyone. There's 300 odd registrants. Hopefully over 100 will actually turn up. I know a lot of people said they can't make it live, and we will be recording this and sending this recording within a few hours of finishing tonight. So let's get started. A big shout out to a couple of our sponsors, Dentama Australia, 8 Point Dental Lab. This is part of a series of free masterclasses leading up to our annual 2-day intro to postural orthodontics. 8 millimeters of lower arch expansion, the key to impactful early intervention, a new evidence-based approach to early intervention orthodontics, featuring my brother, Dr. Simon Wong, founder of Postural Orthodontics. Guest speakers, Professor John Mew, the creator of Orthotropics, Dr. Perry Burston, Mr. Enrico Di Giovanni, and Dr. Susan Scher. This will be in Sydney, end of July. We'll be showcasing some of the 145 consecutively treated cases, revealing the 7 steps to straighter teeth, beautiful faces, and better airways. 2-day full event, Dental Education Center. Virtual tickets are available as well on the weekend, for the weekend of Saturday, Sunday, July 29th, 30th at the beautiful, newly renovated Derek Mahoney's Dental Education Center. You can check out the details, straightteethnaturally.com/live. We'll be giving a bit more info about this near the end of the presentation. But first up, let's give a short introduction for those of you who are new to postural orthodontics. And as our guest, welcome. Dr. Simon Wong is the founder of Postural Orthodontics and a leading expert in facial growth guidance and early intervention. He's held the position of visiting professor, co-director of the Orthotropics module at the University of Valencia, Department of Orthodontics, and is a fellow of the International Academy of Dental Facial Aesthetics. Past 13 plus years as the principal of the Clinic Natural Smile Center based in Melbourne, Australia. He's been focused on the correction of early childhood craniofacial development issues, devoted practitioner for the early correction of malocclusion. He's published author with journal and textbook articles on sleep disordered breathing. His most recent article, The Jaw Epidemic, Recognition, Origins, Cures, and Prevention, published in Bioscience, July 2020. His current clinical research at the Orthodontic Department of the University of Alberta, and most recently at Texas A&M under the supervision of Dr. Peter Bashang, will hopefully provide the pathway for the future of orthodontics to be focused on cures and prevention for all orofacial development issues for our children. Simon will give a short 5-minute presentation before he welcomes our main presenter tonight, Professor Narinder Singh, who is an ENT specialist surgeon, clinical associate professor of surgery at the University of Sydney, Australia's oldest and largest medical school, and chief otolaryngology, excuse me if I butchered that, head and neck surgery at Westmead Hospital, Sydney, Australia's largest healthcare campus. Professor Singh is a rhinologist, specializing exclusively in disorders of the nose and sinuses, including nasal obstruction, surgery for snoring, OSA, complex and extended endoscopic sinus procedures, anterior skull-based surgery and rhinoplasty, functional and aesthetic. Professor Singh has a special interest in the role of nasal obstruction in the pathogenesis of dental and maxillofacial disorders. He is considered to be the go-to ENT surgeon for dentists, orthodontists, maxillofacial surgeons, and craniofacial pain specialists across Sydney and New South Wales. So welcome, Professor Singh. Over to you, Simon.
Thank you. When I first started to explore sleep dentistry as a topic, one of the ideas that kept being presented was the significance and importance of sleep studies. And it wasn't until I understood the clinical side of practical management that I realized of the people that we as dentists collaborate, there is no more important a colleague than the ear, nose, and throat surgeon. They are literally the first line of defense for our children because, yes, absolutely, sleep screening is an important diagnostic component, but primary care for the obstructed child has to fall under the services offered by the ear, nose, and throat surgeon. And I was very fortunate. A few years before COVID hit, I had the opportunity to meet Professor Narinder Singh at an airway conference that was hosted as main guest speaker Stanley Liu. And Stanley Liu is a sleep surgeon at the Stanford sleep department. And the things that I learned they were doing in Stanford allowed me to create a broader, higher level understanding of how we need to collaborate with the ear, nose, and throat surgeon. And in Sydney, where Professor Singh operates, whenever I have New South Wales patients, we try to interact with them. And one of the things that I want to do is introduce the methodology of how we communicate with colleagues such as Professor Singh. So I'm going to share with you my screen. And I'm going to go through a very quick review of one of the topics that we cover in our 2-day introduction to postural orthodontics. Screening for airway must be a foundational component of our history taking. Chevron in 2000 produced a pediatric sleep questionnaire, and he found that to be a very valid and reliable instrument in identifying sleep-related breathing disorders. He composed a very simple questionnaire that was incredibly sensitive and had high levels of specificity. And this is a questionnaire that I use routinely in my history taking, and it takes no time in our practice because it's forwarded to the parents before they even come in. The focus of simple observations from a parent of a child who's sleep deprived reveals an incredible amount of information. In 2013, Professor Villa released a very, very powerful aid to rapid and accurate diagnosis of pediatric sleep disorder breathing. And she labeled this the sleep clinical record. This particular screening process I use routinely in my practice. And I teach those who are interested a very simple way of incorporating an incredibly useful tool in the communication with our ear, nose, and throat surgeon colleagues. In addition to our normal orthodontic records, where we look for angles classification, bite relationship, overjet relationship, form of the palate, a simple observation of tonsillar size, Friedman scoring, patency of nasal breathing, deviation of septum, collapse of the nares, simple questions about habitual obstructions of the nose. When combined with the phenotype that we normally diagnose in orthodontic evaluation, we can very accurately build a picture, much like a resident would for their consultants, in communicating significant and important sleep disorder breathing issues. We, as dentists, cannot diagnose sleep disorder breathing, but we can certainly screen for the signs and communicate with colleagues who have the licensure to assist and manage these sickly children. It's important to be able to recognize, when we look in the mouth, the significance of seeing a hole versus seeing a tongue. We have to remember, when someone healthy opens their mouth, we're meant to see a hole. When all we see is tongue, it's a flag. It's a flag for our ear, nose, and throat colleagues to be on the radar. We need to know the mobility of the tongue. A simple measurement, 4 mils, 8 mils, 12 mils, 16 mils from the tip gives us an ankylosing classification. We know what we see in someone's mouth will give clues to whether they have issues with their airways, whether they have issues with sleep disorder breathing. We need to remember there are neighboring structures that sit in the vicinity of where we work. Again, healthy children, when they open their mouths, show a hole. And I remind you, this is not a hole. Our cephalometrics tells us bony structure relationships, but it also gives us clues on adenoids and tonsils, hard palate, soft palate relationships with the hyoid bone, with the tongue. We have an enormous wealth of information that we can share with our ear, nose, and throat colleagues. Because at the end of the day, we're dentists. And primary care needs of our children must always be attended to by medical professionals. So what I'm going to do now is pass on to you, our esteemed colleague, Professor Narinder Singh.
Thanks, Simon. That was a fantastic introduction. I think you've given away most of my talk. There's really not much left for me to say.
I think that it's very important that people understand the collegiate relationship that is never spoken about in dental training, but must be bridged.
Fantastic. Thanks, Simon. So could I just start by really saying what an honor and a pleasure it is to be invited by you, Simon, to speak today. I'm sure the audience is familiar and aware that this is a very educated and elite audience that you've accrued over the years. So it's a real privilege to be able to share some thoughts with everyone tonight. So we might get started. And to begin with, I'll start with a little introduction. Just thanks for the great introduction before for both of you, but I'll run through a bit of my background as well. So this is me back in the 80s, growing up on my parents' farm in Griffith in country New South Wales. So it's about 8-hour drive from Sydney for our international guests. And then I did my undergraduate degree at the University of Sydney and ENT training in the New South Wales program. I then went on to undertake a 3-year clinical fellowship at Guy's and St Thomas's Hospital in London, studying just rhinology, the nose and sinuses, anterior skull base, sleep apnea, as Kian mentioned. That's Guy's Hospital right there, if you can see my arrow, just through there, through Tower Bridge, and completed my thesis through the labs at King's College in London. So I'm the head of the ENT department at Westmead Hospital in Sydney and an academic at the University of Sydney. This is our office in Bella Vista, Northwest Sydney. We do receive grant funding from various organisations, and I am obliged to disclose our commercial funding. So we have a artificial intelligence research collaboration with Microsoft. We're helping ResMed to design CPAP masks, ENT Technologies to design saline rinse bottles, Optinose and Nasus to design nasal spray devices, for which we have a patent pending, and a number of other organisations as well. All right, so we'll get to the meat of the talk today. So today's topic is blocked nose in children. That's what we're going to concentrate on. Now, some of you will be very familiar with this material, but to some of you, it will be a revelation. And so for those who are familiar with it, please do pay attention. One of the reasons I still attend up to 6 major in-person conferences every year on topics that I'm already very familiar with is that I always pick up some new little detail that I wasn't previously aware of. So please do pay attention, take some notes, ask questions, either in the chat or you can raise your hand and we can ask over the microphone or video. Now, typically we do run this session as a practical interactive session so that you can actually implement it in your clinical practice from tomorrow. We normally do this in person. This is the first time we've done it as an interactive session over Zoom. So again, please do participate over the chat and feel free to ask questions and interrupt. And the more you get involved, the more you'll get out of it. So we're going to test our interactivity right now. So please type the word yes in the chat right now. We've got at least 60 participants. Sorry, 116. So we know that we've got people there. Fantastic. Biju, Maria, Emma, Irina. Oh, that's fantastic. Great. So we've got an attentive audience. You're not all on autopilot. Oh, we've got some capital letters there from Nidhi. Fantastic. All right. That's great. Thanks for participating. All right. So now just to clarify, what we're going to talk about today is chronic nasal obstruction in children. So we're not talking about acute obstruction for short-term colds or the flu, and we're talking about children from at least about 6 months to 18 years. We won't be talking about neonates, which are a bit more complicated and specialised often with congenital issues. So Ken, we'll go to our first poll question for the audience tonight.
Okay.
So,
exciting. We're going to do a first ever poll. It's a new function that I've come across. So let's give it a shot.
So the first question for the audience is, do you have any children and how many do you have? So are we able to get the poll up on the screen?
Okay.
Neil's got off to a great start, letting us know.
I'm going to launch it right now. So the question is, do you have children and how many, right? So let me just launch that. Okay, it's launching.
Fantastic.
So
yep, I can see that.
Yeah, hopefully you okay, people are typing in now. So can you see the statistics coming through, Professor Singh, as a host?
I'm not seeing the stats, but I am seeing the question.
Okay, we have 60% participation already. So let's try to get to 95 and then we'll wrap up this quick poll. 65%, almost there. Yep. Let's try to get to 80. We'll stop at 80, shall we?
Very good.
70% participation. Oh, we have a few on shares and Huggies. That's very good.
Yeah, we've got some shareholders in Huggies. That's great.
Okay, excellent. So 72 participation. You just tell me when you want to, shall we end the poll?
That's pretty good. Yeah. What do we end up with? I just can't see the results.
Let's see. Share results. Okay. Do you see the results, Professor Singh?
Very good.
So we've got. Yeah, you read it out. Yeah, go ahead.
Yeah, we've got a pretty good cross section. So no is 27, 1, 25%, 2, 30%, 14% for 3, and 4%, 3 people with who have shareholders in Huggies. So that's fantastic.
All right,
Great.
terrific.
Good. So we do have some participants with kids. Now then, we're going to move on to our next poll question. So the question now is going to be, how common is chronic nasal obstruction in children? And again, we're not talking about brief cold or an upper respiratory tract infection. So we're talking about chronic long-term nasal obstruction. So is it rare? Is it uncommon? Is it common? Is it very common? We'll put the poll up on the screen.
Yes,
So
I've just launched it. There we go. How common is chronic nasal obstruction? 40% participation. Wow, everyone's quickly. I think we'll be done in another 10 or 15 seconds.
Fantastic.
All right, we're almost at 80% participation.
Fantastic. All right,
Okay,
let's cut it there.
Share results. All right,
we've got some results. Oh, what a well-educated audience. So we've got very few people thought rare. Again, very few people thought uncommon. So 1% for each of those. 58% thought it was common, and 40% thought it was very common. Well, let's look at the answer. You're all wrong. It's extremely common.
Oh,
yeah,
that was a trick question. That was a trick question.
It was a trick question. Yeah. So it's a very, very, very common problem is chronic nasal obstruction in kids. So I want this to be one of the take-home messages from today, and we'll go through those all in a moment. So now that you've been tricked, we're going to ask you the next poll question. I think this is the last one for the night. How serious a problem is chronic nasal obstruction in children? So is it a trivial problem? Is it a minor medical problem? Is it a major medical problem? Or is it a serious medical and social problem? Let's see what everybody thinks.
Yep, up to 50%, 60%, 70% participation. Oh,
fantastic.
76, 77. All right, that's good enough.
Great. What a great audience.
It is. If we get to 80, come on, just need one more. Oh, wait, hit 80. End poll, share results. There you go.
Fantastic. Great. So we've got a really great response there. So 0% said trivial, 4% said minor, 20% thought major, and 77% thought it was a serious medical and social problem. So no trick question this time. That's a great response. So yeah, what a great educated audience. All right. So now I'm going to ask you, what are some of the consequences of nasal obstruction in children? Which organ systems are affected by nasal obstruction in children? Perhaps if everyone can just type it in the chat, what you think are some of the key areas affected by nasal obstruction in children. So does it affect the nose? Does it affect the lungs? Does it affect the ears? What sort of things can be affected? Yep, so we've got some lungs, we've got brain, behavior, jaw development, mouth breathing, lack of sleep, dentomaxillary. Yeah, we've got a multi-part answer there. Fantastic. This is a great audience you've got, Simon. They're really engaged. I love it. All right. So let's run through some of those in briefly. So these are some of the things that some of the areas that are affected by nasal obstruction in children. And we're now going to go through each of these areas in a little bit of detail. So the first thing, of course, is if there is a blocked nose, then the child will have mouth breathing. And so we have to ask ourselves, does that matter? Does it matter if kids breathe through the mouth? Well, the first thing to say is that humans are nose breathers. Mouth breathing is really only plan B for brief emergencies. We're not intended to breathe through the mouth normally. So what are the effects of breathing air through the nose? So what benefits does that give us? What are the physiological effects on air that we breathe through the nose? Why don't we get people to type that into the chat? We've got some great participation so far, so we'll keep it up. And remember, the more you participate, the more likely you'll remember this. So what does nose breathing? Moisturizes the air. Fantastic, Mohammed. That's great. Filtering the air. Great, Cindy. Yep. Humidification, nitric oxide. What a great audience. Yeah. So those are certainly the sort of key physiological effects of breathing through the nose, which then logically follows that if we are breathing through the mouth, we're now getting air that is cold, dry, and unfiltered. So what are the consequences then on the lungs of mouth breathing? So if we're breathing air through the nose that's no longer warmed, humidified, and filtered, what effect does that have on the lungs? And we'll certainly talk about the jaw and other issues in a moment. But perhaps if you can type in the chat what you think that effect that may have on the lungs. Irritation, very good, Win. There's a clue in that picture that might give it away. Effects on ventilation, drying out, asthma exacerbations, fantastic. That's very good. So certainly asthma exacerbations, a higher risk of chest infections and inflammation, as you've mentioned there, Maria, and certainly sore throats can be a factor. So what about sleep? What effects does nasal obstruction have on sleep? And again, we're talking about broad terms at this stage. Again, just type in the chat what sort of impacts that can have on sleep. And again, there are some clues in the pictures there. So sleep-related breathing disorders, Ella, that's fantastic. Sleep interruption, very good. Kian, you may need to take that question about the recording. And snoring from Biju has asked a question. Very good. Yeah, so certainly sleep disturbance is an obvious issue. Sleep-related breathing disorders, snoring, and in severe cases, obstructive sleep apnea. So then further consequences, as has been mentioned in some of the chat already, bruxism, bedwetting, and behavioral changes. And interestingly, in adults, typically we see where there is sleep disordered breathing, we see daytime sleepiness. In children, we may see daytime sleepiness, but we often see the opposite. We often see hyperactivity, irritability, inattention, reduced focus, misbehavior. And often once we correct these issues, we do see an improvement in this, and parents really do notice the difference. Now, we're going to speak a little bit about facial growth. Now, clearly, this is not my area of expertise, and Simon, I'm sure, will discuss this in inordinate detail later on and during the two-day course, Introduction to Postural Orthodontics, but we'll briefly mention it today. So certainly when there is nasal obstruction, then we do see an impact on facial growth. And typically where the mouth is open, so normally when the subject is breathing through the nose, then we'll see the tongue resting in the roof of the mouth, directing the jaw, sorry. But when people breathe through the mouth, the tongue now drops down, which no longer gets the pressure effect on the jaw to lead to maxillary and mandibular development. There's a nice little video here that we'll just play just to illustrate that concept. So in the is the video playing okay, Simon?
Yes, yes.
Fantastic, thanks. So this is demonstrating normal breathing through the nose, and you can see the tongue resting up in the roof of the mouth. In this particular instance, we're showing obstruction of the nose by an enlarged adenoid, although there are other causes of nasal obstruction. And we can see the tongue drops down when the nose is obstructed, which then leads to, we no longer get the pressure effect in the maxilla, which leads to over effects of the buccal muscles and a narrow, high arched palate, which is going to be demonstrated in this video shortly. So it's a nice little demonstration just to help clarify some of the broad brush stroke concepts, which again, Simon will go into in a lot more detail. All right, so the next quiz question in the chat. So what are the consequences of nasal obstruction on facial growth? So on the facial appearance. So what sort of things do we see? What are the characteristic appearances? So a rough term for that is the adenoid facies, but it can be caused by any other cause of nasal obstruction. It doesn't necessarily have to be adenoid facies. So we've got yes, correct, that's the long face syndrome is otherwise known. Yeah, that's great. So we've got some venous pooling, the panda eyes as they're called, effects on growth, dry lips, fantastic, narrow face, high nasolabial angle. This is great. What a great audience. Yeah, so these are some of the obvious things that we'll typically see. So open mouth breathing, the panda eyes, dark circles under the eyes, the flat mid face, long lower face, and dental issues, which again I won't go into in detail, but I'm sure Simon will cover in great detail.
Professor Singh, if I may interrupt,
Yep.
there's a question that's come through. If I may read it out for the attendee, is anonymous submitted. A lot of my patients' parents say that they were told the ENT didn't see infection or enlarged tonsils. So they were told that everything is fine, even though the child sleeps poorly and has obvious tooth wear and high vaulted palate. What do you recommend them besides getting a second opinion?
Fantastic. So that's a great question. We see this problem repeatedly. Unfortunately, this is an area that's not actually well taught in ENT training, certainly in Australia, and I'm sure it's the same overseas as well. And in fact, a lot of my education in this area came from some of my academic and clinical dental colleagues, which then spurred me to do a lot of postgraduate research and training in this specific area. Now, to specifically answer that practical clinical question where you can see the obvious signs that we've just discussed, you send it to the ENT and they just say, look, no, they're fine, there's nothing wrong, don't need to do anything. There's a couple of ways that this can be approached. So the first thing is I do recommend that you try and engage with ENTs in your area, and you will eventually find someone who has a particular interest in this area and is educated on it and is interested in looking after these sorts of patients. You can also try and gently encourage your ENT to participate in events such as these and to have some discussions with them around it. And again, that's the most important thing, is they have an open mind. And I do appreciate that a lot of ENTs have sort of fixed ideas and don't like being told by their dentists about this sort of thing. So it's something you have to broach in a very politically correct way to start that discussion. Certainly in Sydney, I can advise some people, but in other parts of the world that might be harder to do. So another question there: what if you live regionally or rurally and not many specialists available to reach out? Again, a really difficult problem. But in that case, that's where you're going to be less inclined to look for another ENT and perhaps work on trying to help educate your ENT about some of the issues. And it's a slow process, so they're not going to be converted overnight. It will take time. And again, one of the reasons that I became interested in a convert in this area is that I had dentists who headhunted me. So some of the key dentists in Sydney actually, approached me. We had long discussions about this socially. Some of them were so enthusiastic they actually came to the operating theatre and watched me operate. And we had one in particular who's like, back in those days, I used to operate till late at night, till midnight, 1 o'clock most operating lists. And he stayed till the very end. I tried to talk him out of going home, but he was really interested in it. And they're some of the best referrers because they fully understand what's going on, and we make a fantastic team then. So I do appreciate the problem. We will move on, but I can certainly understand how that can be a problem, and perhaps we can discuss some of the practical approaches one-on-one at a later time.
Terrific.
All right. So moving back to the teeth again, I'll cover this briefly because I know Simon will cover it in great detail. So these are obviously some of the issues that can affect the dentition. And again, can result in orthodontic issues, which I'll go over very briefly. So now we'll talk a little bit about the ears, and perhaps people can put it in the chat. What do you think? What effect nasal obstruction can have on the ears? How do you think that might be affected? And there's a clue in that little illustration there. Yeah, so fantastic, Neil. So it certainly can affect the hearing and speech, and glue ear. Very good, Ellen and Irina. So particularly if there is enlargement of the adenoid or even chronic infection of the adenoid, that can obstruct the eustachian tube, which runs from the ear to the back of the nose. and that can result in recurrent ear infections. Recurrent ear infections, often they'll clear up by themselves, but if the fluid in the middle ear persists for 3 months or longer, it's known as glue ear, and that's very hard to clear by itself. So then we typically do need to put grommets in. And when that occurs, the patients typically will experience hearing loss, which, for us, that might just result in muffled speech, a 30 decibel loss. But for a child where hearing is critical to develop their speech, then that can have significant long-term impact. So if the hearing is affected, it then affects their speech development. Speech development then leads to social isolation, which leads to poor school performance, which can then lead to job prospects issues, and a lot of complications down the track from something that's relatively easily treated. So definitely something we need to look out for. And then the consequences for an adult, if we don't treat nasal obstruction in a child for a long period of time, is it can have impacts on the facial appearance and part of the anatomy, which can then lead to a predisposition to sleep apnea in adults. All right, so I want everyone to write this down. This is if you learn nothing else from this talk, this is the key message, that chronic nasal obstruction in children is a very common condition with potentially serious medical and social consequences. And all of these consequences are completely preventable with accurate diagnosis and treatment. And where the consequences have occurred, if we intervene early, we can reverse many of the changes. Sure, if we do leave it for too long, sometimes it's hard to reverse them, but if we intervene early and we recognize them, we act, we can actually avoid a lot of these issues and reverse them. So now we're going to do a little bit of anatomy. Don't panic. This is going to be super simple. Again, I just want to do this all broad brushstrokes, so we just get some clear messages that'll stay with you. So this is a coronal section of the face. So you can see the eyes there. This is the nose. These are the sinuses coming off the nose. So the first question I'm just going to ask the audience, just type it in the chat. What's this structure right here in the middle? Just type it in the chat. The septum. Fantastic. Good on you, Cindy. That's great. Okay, very good. So that's the nasal septum. And then second thing, what's this structure right here off to the side? We get someone to type that into the chat. The inferior turbinate. Fantastic. What a great audience. So as I said, really simple. We're not going to tax you and ask you too many complicated questions. So this is the septum in a sagittal view, and it's made of a large piece of cartilage. You can grab your own septum, move it around. And there are actually 7 bones that contribute to the septum. I'm not going to ask you to memorize them. And then that was the medial view. Now this is a lateral view. So we're looking from the middle outwards. Again, simple question. What's this structure right here? Just type it in the chat. The adenoid. Fantastic, Saba. That's great. And again, this structure just there. That's the inferior turbinate. Fantastic. So that's the key one that we're interested in, the inferior turbinate. So the inferior turbinate, it does contain vascular expansile tissue. So that the inferior turbinate acts to regulate the flow of nasal air. So it can increase in size and reduce in size to regulate flow. And where there is allergic rhinitis, we can have pathological expansion of the inferior turbinate.
Yeah, Professor Singh, there's a quick question
there. Yeah.
Interrupt?
No worries. We'll take the question. So the question is, aren't grommets a compromise? Why not address the problem when the problem lies at the eustachian tube? Grommets are like punching a hole in the bottom of a bucket because it's overflowing. So that's a fantastic question. I love that we've got some skeptics in the audience. So hopefully we'll address your concerns. So what I would say is absolutely the correct response is initially, Barry, to address the underlying cause, which typically is either adenoid hypertrophy or chronic infection of the adenoid. So that's the key thing to address that. Now, when it comes to ear infections, typically a child will get an ear infection, again, because of obstruction or chronic infection. And then most of the time, the fluid in the ear will build up and then it will clear away as the infection goes away. But in a small number of children, that fluid will stay and it will stick around for 3 months or more. And what the literature shows is that once it stays for 3 months or more, that fluid becomes really thick. And when it's really thick, it is not going to drain away by itself. That's why we use the term glue ear. So if I was to show you an illustration of that, you'd see it's you literally use the sucker, and once we make the incision in the eardrum, we suck this fluid out, and often you can pull it back about 10 centimeters. It's that thick. So for those patients, we have to do a myringotomy, an incision in the eardrum, suck out the thick fluid, and then put in the grommet to allow that ear to return to normal. So allow the mucus lining of the ear to return to normal. But if it's just simple infections or fluid in the ear, just thin serous fluid, we don't need to put grommets in. Just treating the adenoids is typically enough. So I hope that answers the question, Barry. Was there another question there?
Yes, another question from...
Yeah. So the other question was, does excess earwax have anything to do with adenoid hypertrophy or other causes of nasal obstruction? So that's a great question. So in general, there is no particular relationship between adenoid hypertrophy and earwax. So in general, in some patients, we do see where they're very allergic, very atopic. They do tend to produce more wax. And in the majority of children and even adults, earwax, the ear will take care of itself. So the skin of the ear canal will grow outwards, take the wax with it. We don't need to use cotton buds. We don't need to use anything else to clear the wax. It looks after itself. Typically, it's when people use cotton buds, they'll get some of the wax out and the rest will be pushed deeper into the ear, and then it becomes obstructed, and that's when it has to be manually removed. Or that's where we use things like water-based agents to try and break it down, or suction or curette to remove it. Now, some ethnicities, earwax can be more problematic. So in Southeast Asian patients, as those of you are familiar, I'm sure you're aware, the earwax does tend to be a little bit harder and drier. So it can be a little bit more challenging to see the ear clearly. As ENTs, we'll typically remove the wax using suction or a manual curette, to remove it. If they do come to theatre, we'll remove it under the microscope. With kids, some of them will participate and let us do it. Some, they won't let us anywhere near their ear. So it can be more of a challenge. Okay. So we won't spend too much time on earwax just so we don't get too sidetracked. A question from Sue Ann: is it okay to use steroid spray like Flixenase for long periods of time for children? Great question, Sue Ann. We're going to come to that. So we'll just put a pin in that for now, and we will come to that. All right, so now next quiz question. So we're going to type this in the chat. I want you to tell me what are the 4 commonest causes of nasal obstruction in children. So just type it in the chat. What do you think the commonest causes are for nasal obstruction? So Mohammed thinks allergy. We've got septal deviation, allergy, septal deviation, adenoids. Very good. Adenoids, we're just missing one. Polyps is less common in kids. Fantastic. That's some great answers. So let's have a look at them. So really the number one cause by far and away is allergic rhinitis in kids. Very common in kids, particularly in Australia and particularly in developed countries. There's not a lot of theories as to why that is the case. In fact, every decade we see the incidence of allergic rhinitis in children increasing year after year, particularly in developed countries. There was a popular theory called the hygiene hypothesis, where we thought insufficient exposure to dirt for kids leads to then the immune system turning on the body rather than addressing allergies, but rather than addressing infection. But that hypothesis has sort of lost favor. So allergic rhinitis, certainly the commonest cause. Adenoid hypertrophy would be the second commonest. Inferior turbinate hypertrophy, the third. Septal deviation is much less common in kids. So in adults, it is probably one of the commonest causes, but in kids, that's a much smaller percentage of causes, but it is something that we have to look out for. All right. So rare causes, that we just have to be conscious of. So very rarely kids will push things up into their nose. Typically, if we'll know that happened because they'll have a foul-smelling discharge from one side. Very rarely, they may have choanal atresia that was missed at birth. Neoplasias are, of course, very common. And cystic fibrosis, again, very, very uncommon cause. So the question, does mouth breathing cause nasal obstruction? It's so Hazel, more the other way around. So nasal obstruction leads to mouth breathing. Typically, what we see in kids is that the reflex is that if the nose is clear, then they will breathe through the nose. And it's only really when the nose is blocked that they will mouth breathe. Now, in some kids, they do develop a habit, and that's where myofunctional therapy can sometimes come in, which we'll discuss later in the talk. Ella's asked a question, how often do we see concha bullosa in kids? It's much less common, but it does still occur. It can affect the breathing. In general, for most, certainly for the younger kids, we typically are less inclined to address it, but for the older kids, we will address it. We won't spend much time on concha bullosa today because I really want to try and get the key issues firmly imprinted in everybody's minds today. All right, so now the next question, we're going to talk about a typical patient that presents. Mum says he's a 3-year-old. Mum says he always seems to have a stuffy nose. So I want you to type in the chat, what questions are you going to ask the parents for the history in this child? And again, Simon's covered some of those topics in the questionnaires, but let's get you to type some questions there. And the reason I want you to do this is because tomorrow you are going to ask these questions of your patients. So if you don't ask them, if you don't remind yourself now, you're not going to do it tomorrow. I can guarantee you'll pay attention, you'll listen, and you'll forget it all when you start seeing patients. So I want you to actually type in the chat. Yeah, that's great. We've got some great questions there. Questions about allergy, tonsillitis, ear infection history, teeth grinding, fantastic, snoring. Very, very good. Great. So we'll go through some of those in a bit more detail. So we're going to ask about the obvious ones, blocked nose, mouth breathing. We're going to ask, is it constant? Is it intermittent? Does it come and go? Is it worse at night? Is it worse when they're asleep in the car, in the back seat? We're going to ask about snoring. And not all kids will snore, but a lot of them will have heavy breathing or noisy breathing. The parents will report. We're going to ask about dry mouth. We're going to ask about halitosis, bad breath. This is a common thing seen in kids where they'll have bad breath from mouth breathing at night, which changes the oral flora. We're going to ask about their sleep quality. Are they restless? Do they toss and turn? Do they have poor quality sleep? Do they wet the bed at night? We're going to ask about their behavior. Have you noticed that there's a change in their behavior? Are they irritable, poor concentration? They lose their temper easily. And then we're going to ask about the dental issues. So do they grind the teeth at night, orthodontic issues or concerns? And then we're going to talk about history of allergy, which has been mentioned there, I saw before. We'll go into it in a bit more detail as well. So we're going to ask about seasonal allergy, perennial, do they have a runny nose, itching, sneezing, watery eyes? What sort of triggers do they have? And what sort of family history of allergy do they have? Again, if one parent has allergy, that significantly increases the risk. Both parents markedly increases, multiplicative. And we're going to ask if it's unilateral, if we're looking for foreign bodies. And one of the a simple thing we can do is just ask the parents to just record a video of the child sleeping. And so that way we can see firsthand exactly what sort of, the severity. And these days, everyone's got a smartphone, they can easily record it. So this is a simple way that we can ask parents to record. We've got a question there. So can nasal obstruction be due to ear canal anatomy that doesn't allow sufficient drainage and therefore fluids build up and inflammation occurs? It's more the other way around. So nasal obstruction can contribute to a compromised ear canal anatomy rather than the other way. Okay. Now, so the physical examination, I'll just skip forward a little bit just so we don't take too long. I'm conscious of everybody's time. So the things that we're going to look for when it comes to physical examination, all of the things that we mentioned, mouth breathing, dark circles under the eyes, the panda eyes, the long flat mid-face, dental issues, which again, Simon will cover in more detail, orthodontic issues. We're going to look for signs of allergy, which we'll cover in a moment. And we're going to perform, so as an ENT, we'll perform anterior rhinoscopy and nasal endoscopy. I don't expect the audience, dental colleagues to do these things, but at least it's good to at least know what we do. So for nasal examination, we do use a headlight, and in adults we'll use a speculum, but in kids we don't typically need to. We can just lift the tip of the nose and get a pretty good look. So I do recommend using a headlight. I'm sure this is with this enlightened audience, most of you are familiar with headlights and have them, but I do recommend them rather than a torch because it does free up both hands. It gives you focused light down your line of sight, so you don't get shadows like a torch. And I'm going to have a quiz question for the audience to keep you all on your toes. So do we have any Latin scholars in the audience? Does anybody know what the Westmead motto means? Fax capitalis mentem illuminat. Any guesses as to what that might mean? Simon, are you a Latin scholar? No, it's a lost art these days. something illuminate. Good on you, Robbie. Where is my son when I need him? I didn't think anyone took Latin anymore. You must be from the UK, Nada. Fantastic. So look, knowledge is important. We're getting there. So I'll enlighten me. Very good. Yeah, I'll put you out of your misery. Illuminate thought. Very good. Getting close. So fax is torch or a light. Capitalis is the head, and mentum the mind, and illuminate means illuminate. So the headlight illuminates the mind. Okay, that's what that means. Right. So very apt for ENT surgeons. So this is a traditional head mirror. Not many people use that anymore, but some of you, the older members of the audience, may be familiar with it. What we typically use as ENTs is this device, the Vorotec. It was actually, it has a converged field of view. So it's like two little periscopes that direct the field of view down the middle. So you can see down narrow passages. It has illumination and 1.5 magnification. It's actually invented by John Boroth, who's a practicing ENT surgeon in Adelaide. It's very useful and certainly can be used in other specialties as well. There is an earlier version of his device that's made by Welsh Allen, not quite as good as the Vorotec. And of course, there's simple versions that you can use, but I'm sure all of you have loops and headlights, so I don't need to go into that in detail. I do give this talk to GPs as well, so that's why we include that section. So when we look in the nose, we start with anterior rhinoscopy, looking at the septum in the middle and the turbinates on either side. Really, with kids, what we want to look at is the inferior turbinates, and we want to look for signs of allergy. And typically with allergy, what we'll see is pale, whitish, boggy, moist turbinates. So they're typically not red and inflamed. Allergy is typically sort of more white and very sort of boggy, lot of fluid. So these are the kind of things that we'll typically see with kids with allergy. We'll see this thing is called the allergic salute. That's when they do this all the time, right? And often you'll see this line just on the nose, and that's from them doing this a lot. Okay, so it becomes a little crease. You'll have what they call allergic shiners, which is again the sort of panda eyes, the venous congestion under the eyes. The tonsil grading score, I won't go into detail, but Simon's already mentioned it. It's a 1 to 4 staging, 25% of the airway, 50, 75, and touching. We won't spend much time on tonsils today. We're really just going to concentrate on the nasal airway, and we can certainly do a tonsil talk on another occasion. Now, typically at this point, we'll perform a if we're in person, we'll do a nasal endoscopy on one of the audience. People really do enjoy seeing a live nasal endoscopy. We've just got a couple of questions. Let me just quickly look at those. So, would you recommend dentists to refer to orthodontist if ENT is not familiar with dental issues associated with nasal obstruction, especially if number of specialists are limited, and especially if the patient is too young for early orthodontic intervention? If this is offered, past experiences, some orthos are skewed to achieve dental harmony rather than anatomical harmony, and tell parents to come back when the patient is 11 or 12. Yeah, look, ideally, if we can address the nasal obstruction, it will make the entire orthodontic process a lot easier. certainly orthodontic appliances and interventions can be applied without addressing the nasal obstruction, but it's a little bit like pressing the accelerator and the brake at the same time. We just won't find it as easy a path as if we try and clear the nasal obstruction. Next question, is it common to see the lateral alar cartilages leaning inwards in young children? Yeah, so we won't spend much time on nasal valve collapse today. That's probably the topic more for another talk. It's something that we do see in adults where there's been long-term nasal obstruction and mouth breathing, where it's almost the case of it's almost like a muscle that hasn't been used much. We'll see weak cartilages that tend to collapse. Addressing that is a more complex issue in adults. The most effective technique that I've developed these days is to use what's called a butterfly graft. In the past, we used what's called alar batten grafts. There are less invasive options, such as the breathe right strips or internal dilators, but we won't spend much time on that today. But in general, with kids, we don't see it as much. It's more when they're older and it's developed over time. All right, so we'll move on. All right, yeah. So these are the scopes that we use. So we certainly in our practice we perform nasendoscopy on every single patient that walks through the door at their first consultation. In adults, we use a 3.4 millimeter scope. In kids, we use a 1.8 millimeter pediatric scope. We do spray the nose, so it's numb. And with a 1.8 millimeter scope, you can scope any child. There's no excuse for not doing it. And the advantage of performing the scope is we see exactly what is going on. And more importantly, the parents see exactly what's going on. And we show them pre-op and we show them post-op so that there is absolutely no doubt in their mind that they're getting the right treatment and they can see the outcome. And if things are not perfect at the end, they can see why that is as well. So we'll go through that in a bit more detail. I'm just going to show you a little video which demonstrates what nasendoscopy involves. This is in an adult, but we do the same sort of thing with kids. So you can see when we put the camera in through the nose, this is the right side of the patient. We can see the septum on the right, inferior turbinate just there on the left. That's the middle turbinate now. We're passing it through the nose. That's what's called the middle meatus. We don't look too much at that in kids. And then as we go further back, we're going to see the postnasal space at the back. This is an adult where there's no significant adenoid hypertrophy. And that's the eustachian tube opening over to the left of the screen. The area just up here is called the fossa of Rosenmuller, where that arrow is pointing. We often see cancers hiding there in adults, but not in kids. And then we go all the way around. We look at the soft palate at the bottom of the screen. We see the base of tongue and the lingual tonsil. Then this is the epiglottis just here. And then we'll see the vocal cords in a moment, and we'll get the patients to phonate. We'll get them to make an E sound, and we'll see the cords come together. So you can see the vocal cords just there. In a moment, you'll see them come together just like that. So we can test for movement of the cords, and then we'll come back and we'll look at the other side. And we do this in every single patient, adults, kids, everybody. Now, kids, there'll be a few kids who will find it difficult to cooperate. It's not because the scope is too big. The 1.8 millimeter is very small and easily tolerated. It's more just the thought of it that can sometimes upset them. And just to reiterate, this is just a picture from the office. You can see we have screens everywhere for myself, for the patient, for the parents. We're marked with left and right. So as we're scoping, we're explaining things. If you have a look at the left of the screen, you'll see the turbinate. We'll show them the adenoids. And again, we'll show them before and after. So there's no question in their mind. All right, so we're going to talk a little bit about investigations. Now, these are some of the investigations that are available, and we'll go through all of these in a bit more detail. So there's various options for allergy. These ones are less required typically, but we'll talk about them in a bit more detail. Now, how are we doing for time, guys? Just let me know if I need to speed up. I am conscious I don't want to keep everybody up too late.
Okay. I think, how much more do you have to go with the presentation? We're gonna.
I'd probably say it's about a 10,
okay,
10, 15
perfect.
or so. Yeah.
So what we'll do is we're just going to do a quick introduction about our event in July, and then come back to your final 10, 15 minutes of presenting. Okay. Terrific.
No problem.
All right, so let me just, if we could stop sharing for a second, and then I'll get to my presentation. 1 second. Okay. Hopefully the blocks will disappear this time. All right, can you see my screen okay? Any gray blocks, Simon? All good? All right, can you hear me okay? Okay, terrific. So, as mentioned at the very beginning, for those who joined us a little bit late, we're running a series of free masterclasses leading up to our annual event, our 2-day intro to postural orthodontics, early intervention, 8 millimeters of lower arch expansion, the key to impactful early intervention. It's a new evidence-based approach to early intervention orthodontics, featuring my brother, Dr. Simon Wong, will be the main presenter. We have a few other guest speakers. Professor John Mew, who'll be beaming in from the UK, creator of orthotropics. Dr. Perry Burston will be presenting, another ENT surgeon, but from Melbourne. Professor Singh, we're going to invite you. We haven't actually told you, but you'll be a guest to attend if you can make it that weekend. So if you want to meet Professor Singh in person, even though he won't be a guest presenter, but he'll be there. If you can make it, please join us. The weekend of, when is it? 29th and 30th of July. So it's a weekend. Perfect. 8:30 in the morning till 5 p.m. You don't have to RSVP tonight, Professor Singh. No. Whenever you get a chance, let us know. Or you can join via virtual, means if you can't physically make it. But it's in your neck of the woods, hopefully not too far from where you live, in Sydney, Australia Dental Education Centre, Derek Mahoney's newly renovated venue. 145 consecutively treated cases. I think this is one of the main points of interest for a lot of people who wanting to see how my brother has developed this new methodology to develop straighter teeth, beautiful faces without extractions and better airways. It's being researched, all his consecutive cases in Alberta and Texas A&M by the folks like Professor Peter Bishang, one of the leading orthodontic researchers in the US, if not the world. And we're getting, positive feedback so far. End of October, it's been a 3-year journey. Still waiting for, some of the official research to be, published and so on and so forth. Hopefully later this year, but we'll wait and see. But if you're interested in adding early intervention into your practice, if you're passionate about helping children specifically around 3 to 10, ideally 8 and younger, but between that sort of range, develop this using the postural orthodontics techniques, presenting, $9,000 solutions for a 9 to 12 month treatment, starting with your existing patients who know, like, and trust you, learning from my brother, who, for some people, like even Mike Mew, the son and driving force of orthotropics at the moment. He's got 300,000 subscribers. Now, if you check out his mewing techniques and so on and so forth on his YouTube channel, learning from the best of the best, do join us and join our community of already 275 dentists who have joined the 2-day intro program over the last 3 years. Join our closed Facebook group. We're on this mission together, and standard ticket prices. We're in early bird at the moment, so you can save about $300. A standard ticket is $1,200 US, about 1,800 Aussie. Or you can join at the premium ticket, where you get the recordings of the event as well. And those who are keen, if you join at the premium level, you get instant access to the recordings from last year's event. So you can get started straight away and still turn up in person and treat it as a refresher. Those who can't physically make it to Sydney, we have a virtual live stream ticket option. So you can watch from the comfort of your home, wherever you are. And that's also at early bird prices of $11.97. Yes, so you get instant access if you buy a premium ticket or the virtual ticket to last year's 2-day event. The same core content. The guest speakers will probably present slightly different topics, but you can get started literally, tomorrow if you want to get into learning more about early intervention postural orthodontics. So we do have a special offer for the 115 people who are still here tonight. If you enroll by this weekend, we've got a special. Those of you listening in the recordings, we'll send the recordings of this out same day, probably today. So you've got a few days to check out the presentation. Go to our website, learn if there's a free webinar presentation that explains a bit more about the two-day event. And, we're going to offer a $100 discount for, watching this presentation here tonight. So just email us. You can't get the discount on the website. We haven't coded it in. It's just a manual thing. So we'll send you a separate invoice. All right. So you just need to email us at info@straightteethnaturally.com. We'll put it in the chat box, subject $100 off, and we'll get our team to send you the discounted pricing for, any of the ticket categories. All right. So instead of $11.97, it's $10.97, et cetera, et cetera. I think that's about it. It's a 100% money back guarantee. Attend both days. If you don't find it's useful, then we'll send you a full refund. All right. So one thing we want to mention, there's a lot of graduates here joining us tonight. It's a new service we're putting in place over the next month or so. Reach out to us if you want Simon to design your appliances. If you've been having any difficulty with that at all before you get the hang of it yourself, feel free to email us. And we're having a new service here where Simon will work very closely with Enrico to get your appliances designed for you. And those of you who want Simon to supervise your cases, over a year or whatever period, join our advanced program. So you can submit your cases and x-rays and have Simon personally mentor you on your day-to-day activity, so to speak. All right, so there's an application page here, straightteethnaturally.com/application. Back to Professor Singh. All right, we'll have questions at the end of Professor Singh's presentation. I'll stay on a little longer to answer any questions regarding our two-day event. So we hope to see you there. All right, back over to you, Professor Singh.
Fantastic. Thanks. I'll just get this back up. Good. Am I back on screen?
Yes, you're back on. Good.
Yes.
Fantastic. Let me just get my chat back up. Very good. Okay, so I think what we'll do is, just in the interest of time, we'll fly through the rest of the talk, and then we'll go through any questions if there's time and there's interest at the end. So then, as far as investigations are concerned, as far as lateral airway X-ray, in general, my advice still is that the gold standard is the nasal endoscopy. That really shows in incredible detail what the cause of the obstruction is. And really, I find that a good history and nasal endoscopy is far more accurate than an X-ray. For allergy, now skin prick tests are the most accurate tests, but blood tests, the official name is immunocap. Traditionally, they've been called RAS tests, and they can be performed. So generally, so again, we have an allergy nurse in our office, and again, everyone that walks through the door, adults, kids, they get tested for allergy, even if they don't think they have it, because the number of people who have it and don't realize it is incredibly high, particularly in Sydney. So we find that generally from 6 or above, kids will tolerate skin prick tests well. Under that age, if they're well behaved and tolerant, they can tolerate skin prick tests. But otherwise, we'll typically, when we do a procedure, we'll perform blood tests at that time routinely on every child that has an operation to look for allergy. And the common things we look for, pollens, house dust mite is probably the biggest one. That's going to cause nasal obstruction at night. Pets can be an issue, mold and cockroach. They're probably the commonest ones that we do in kids. Now then, just very briefly, we'll just talk a little bit about allergy. So as I'm sure you're vaguely familiar from back in your early days, it's an IgE-mediated inflammatory response to allergen exposure. So it starts with allergen exposure, which then leads to IgE, which a specific IgE, which then when it gets re-exposed to that thing, it will trigger cytokines and inflammatory agents, which then lead to the allergic response. The options for management for allergy, we'll touch on this very briefly. Allergy itself can be a very long talk, but basically the simple measures are avoiding the allergen, particularly for house dust mite. There are a number of things we can do. We give patients a handout that tells them what to do, and mainly involves making their bedroom minimalist. So getting rid of any carpet, clothes lying around, curtains, washing the sheets over 55 degrees once a week, getting anti-allergy covers for the bedding, taking the bedding off the bed every morning, putting it over a chair, opening a window. So there's simple things that can be done. Saline can be used. Medications, these are the options that we've got, and we'll touch on those briefly. Immunotherapy is an option, and then surgery. So just to go through these quickly. So again, that's for house dust mite avoidance measures, concentrate on the bedroom. Pets, even though we identify allergy to cats or dogs, nobody ever gets rid of their cat or dog. So there's no point even trying, but we do try and encourage them to keep them out of the bedroom. And mold can sometimes be an issue for allergy. For saline irrigation, the simplest option for kids is sprays, which some kids will tolerate, but not all. And then the squeeze bottle, if they'll tolerate it, that's a bit more effective and is higher volume. Intranasal steroids, and we'll get to that question that was raised earlier in the night. So intranasal steroids, they don't work straight away. Typically, they need to be used on a daily basis to be effective and to build up. So they're most effective with continuous use. As far as efficacy, all the companies will say that their one is better than the other. Largely, the efficacy is similar. The main difference is with side effects. So the first generation steroids had much more systemic absorption, whereas the newer ones, mometasone, fluticasone, and the like, have 30 times less systemic absorption. And in Australia, mometasone is available over the counter because it's off patent, whereas some of the others are still on patent, so they need a prescription. The question about long-term side effects. In general, the side effects are these sort of issues, which by and large we can avoid with the correct technique. So we give everybody a handout. If anybody wants a copy of it, there's a detailed handout we give. Just shoot through an email and we'll get our staff to send it out to you. But basically, the main thing is to put the nozzle in the nose and point it out to the side so that it gets on the turbinate and lateral wall. And we don't want to point it towards the middle, because that's when it hits the septum, it's more likely to cause irritation and bleeding. As far as the question of safety, this has been extensively studied. The first thing is there's no significant suppression of the hypothalamic pituitary adrenal axis, and that's been demonstrated in multiple RCTs. There's no evidence of cataract or glaucoma formation with long-term intranasal steroid use. The question always arises about growth suppression in children. And what the data shows is that with the first generation steroids, when it was used for long periods of time at high doses, there was some impact. But once that medication was stopped, then that completely resolves. They actually catch up to the height they should be. And when we use the newer agents, so all the third generation agents, mometasone, fluticasone, and the like, then there is no evidence of growth suppression in children. So it's quite safe to use from about age 2 on prescription. And people do get worried about thinning of the mucosa. That, again, that just doesn't happen. There's no evidence to support that. Antihistamines, not as effective as intranasal steroids. And we normally try intranasal steroids as the first line. And they can be given orally or intranasally. There's first generation antihistamines are sedating, whereas the newer ones don't cause sedation. So they're more commonly used. In general, in older children, so intranasal antihistamines can be used as well as sprays. Again, they're not as effective as intranasal steroids, but they are an alternative. And we can also use combination treatments, which in the past have been used for older kids, but recently have been approved for younger kids in the short term. So that's Dymista and Ryaltris are the trade names for those two combination treatments. Decongestants in general should not be used in children. If they are going to be used, only for a few days, not more than that. Otherwise, they can have side effects. And so basically, we'll talk about a rough guide as to how we manage these sorts of kids. So the first thing to do is we want to identify if there is any presence of allergic rhinitis through the history, the examination, and investigations. Oops, sorry. We'll trial intranasal steroids and saline, and generally a 1 to 2 month trial where the child has been compliant is a pretty good trial. So the question then is when do we refer them to the ENTs? So if there's persistent symptoms after an intranasal steroid trial, or if there's significant symptoms at the initial visit. And again, it's a little bit of a gray area because Trialing medications, for dentists varies from jurisdiction to jurisdiction, so I won't talk about that in detail, but that is something that'll vary from country to country. Now, then when we do refer patients to the ENT, then they'll do a complete systems check. We'll look at the nose, the sinuses, tonsils, ears, the larynx, and the oral cavity. We'll take a detailed history physical examination. We'll review allergy, and we'll perform nasendoscopy. So this is a typical nasendoscopy in a child. So that we did show the one earlier that was an adult. This is for a child. So again, we're going through the right side. That's the septum on the right, inferior turbinate on the left, middle turbinate just there. And we're going to run, this is the 1.8 millimeter scope, the smaller scope. So we're going to run it all the way through to the back. And if you have a look, you can see some very obvious pathology there. So you can see that's a significant adenoid hypertrophy. So that's demonstrating about a 70–80% obstruction of the adenoids, very common finding in kids with nasal obstruction. So we'll skip ahead. So adenoid hypertrophy, just to give you an idea of what we see. So in somebody without adenoid hypertrophy, this is what we'll see in the postnasal space, whereas this is what we'll see in the with enlarged adenoids. And with the nasendoscopy, that's very, very clear. You can't miss it, and the parents can see it, so there's no doubt in anybody's mind. As far as management of large adenoids, we do adenoidectomy. Now, we perform that under a general anesthetic. Personally, although I love technology and always use the latest devices, with adenoids, I've still found that the curette is the best device to remove it. Some people use other devices, diathermy or a coblation or a few other techniques, but I've just found that with adenoids, the curette is still the best option. And typically, we will address the inferior turbinates whenever we address the adenoids at the same time. Briefly, tonsillectomy, the main indications for removing the tonsils are either if they have recurrent tonsillitis. So officially, the statistics are 7 episodes in a year or 3 times a year for 3 years. Most parents will typically request tonsillectomy before they have that many episodes, if they're taking time off school, for instance. And the other indication, so the recurrent tonsillitis was the common indication in the past, whereas now we see that less frequently in developed countries. And the most common indication for tonsillectomy is for tonsillar hypertrophy. So big tonsils, grade 3 or grade 4, and regular daily snoring. Now, the one thing I would say is that these days, the majority of kids we treat with adenoidectomy, treating their turbinates, and allergy treatments. It's less common that we need to perform tonsillectomy. So I would say probably about 1 in 6 kids that I treat will actually need the tonsils removed. So in the old days, it would be routine. If we're treating the adenoids, we take the tonsils out as well. These days, it's not as frequent as we used to do in the past. I won't spend much time on lingual tonsils or tonsillotomy just in the interest of time. This is what we look for with turbinate hypertrophy. Again, the best test is to have a look inside the nose with the camera. And this is the treatment that we use for the majority of children in Sydney. We perform coblation, which is this device, which we insert at various points along the turbinate. It's submucosal. So in the past, people would use diathermy, which is very destructive, results in a lot of damage to the mucosa, a lot of crusting. The patients are in pain, they have discharge, bad smell. So it's not a great technique. But coblation, it's submucosal, so we preserve the mucosa, which is critical for good function of the turbinate, and it just shrinks down that vascular tissue that we showed earlier. So we do it at a few different spots, and the way it works is it generates a plasma field around the tip of the wand. It's at low temperature, so it's about 70 degrees, as opposed to diathermy, which can get up to 400 to 700 degrees. And it's very shallow depth of treatment. So it's a few hundred microns, whereas diathermy can go several millimeters. And just to show what that looks like. So this is a little animation just demonstrating the coblation technique. So this is the coblation wand. We insert it, we inject first to dilate the turbinate. We'll put the device into a few spots and apply it for about 5 seconds at each location. and just withdraw it as we apply it. And we'll do that at several locations along the turbinate. It does take time to do this, so it's not very popular with a lot of my ENT colleagues, but we can easily get the best results. So I started doing this about 15 years ago and haven't looked back. And the other techniques are pretty barbaric compared to this. So that's a little video just to demonstrate that technique. Now, we're going to talk briefly about inferior turbinoplasty. This is something we routinely perform in adults. In kids, we'll typically only perform turbinoplasty where there is septal deviation. So we'll briefly show that video. I know everyone likes to see operative videos. This is the right side. This is the septum. This is the inferior turbinate. We use a microdebrider. It's a device that has a rotating blade, has suction irrigation. And we start by creating an incision just to expose the bone of the turbinate. And then we run that along about half to 2/3 of the length of the turbinate. And then we switch the debrider so it runs in a single direction. And we use that to, you can see, we're actually lifting the mucosa off the bone. It works beautifully to strip the mucosa off without causing any damage. And then we remove the bone and the lateral mucosa anteriorly in the region called the internal nasal valve, the first 1.3 centimeters. That's the critical area where most of the obstruction occurs. So that's where we want to address. And we preserve the turbinate posteriorly, so it still does have its normal function. And again, I could give an entire talk on turbinates, but we'll skip ahead in the interest of time today. So that's basically the turbinate procedure. I'll just jump ahead for that. Septal deviation. So this demonstrates an anterior septal deviation. We don't typically see this as obvious as this. So this is right at the very front of the septum. We often see that in adults, but not so much in kids. In kids, we'll be more likely to see this setup where we see a septal spur, which is deeper within the nose, and we see with the nase endoscope. Okay. Now, with septal deviation, that's uncommon in young children. We can really diagnose it best with endoscopy. And in general, with kids, we try and avoid septal surgery until around the age 15 or 16. Now, there are some ENTs who do perform septal surgery at a younger age. It is a controversial area. So personally, I'm a bit more conservative in this, and we avoid that. And so with kids with septal deviation, the way we'll manage them is to perform an adenoidectomy and either coblation to the turbinates or a turbinoplasty right now. And then we'll perform the septoplasty when they're older. And that typically is enough to get them through until they're old enough for the septoplasty. So to summarize the ENT management, with the majority of kids with nasal obstruction that require intervention, we perform adenoidectomy, coblation to the inferior turbinates, and RAS tests while they're asleep. In some of them with big tonsils and significant snoring, we will add tonsillectomy as well, again, around 1 in 6. If there is septal deviation, which is less common, we'll perform this procedure and inferior turbinoplasty if we need to, and then septoplasty when they're older. And with kids over 6, we will perform skin prick tests in the office. So we then review the patients post-operatively at 6 weeks. We'll perform a repeat nose endoscopy again to check that we've got complete adenoid removal and no adhesions bits getting stuck together. We'll review the RAS test results. And if they're positive, if they've got an allergy to house dust mite or grass or pollen, we'll give them advice on avoidance and a trial of intranasal steroids if required. And if they have significant allergy, we may consider referring them to an immunologist for desensitization. And if they do have any of those symptoms, we'll get them back after 3 months to check on their progress. So what do we do if they're still mouth breathing at 6 weeks? To start with, we'll trial intranasal steroids, even if their allergy test is negative. So the allergy test isn't always 100% accurate. So sometimes they'll have allergy even with a negative test. So we'll try them on intranasal steroids. If that still doesn't work, we'll then refer them to a myofunctional trainer, which is, again, a whole other talk, but we won't discuss that today. And then we'll get them back after 3 months. Now, very rarely, if they are still snoring after that intervention, we'll review their allergy. We'll consider performing tonsillectomy, even if we didn't do it the first time. And then we'll think about doing a sleep study to exclude central sleep apnea. But typically that's in syndromic kids and not in the majority of kids. So So generally, my practice is not to go to the sleep study early for kids and keep it up our sleeve as if they've got persistent symptoms, because we find the majority we can address with the measures that we talked about. And it's more for adults that we routinely do a sleep study earlier. So if there's persistent resolution after 6 months, again, the biggest problem we find is that the parents just aren't compliant with their allergy treatment. We tell them to use sprays. We tell them to do allergen avoidance. The majority of parents, they'll spray it once or twice and then they stop doing it. So then typically at that point, we'll refer them to an immunologist to try and get a bit more strict with compliance. If habitual obstruction is an issue, then the myofunctional trainer. And then the septal deviation, again, typically we'll address that when they're older. But sometimes what we see is that we'll do the procedure at a younger age, say 5 or 6, the adenoids and turbinate reduction. And what we'll find is that as soon as they stop mouth breathing, they now get a much better quality sleep, which now means they'll get proper REM sleep, which means they'll now get growth hormone release. And almost universally, we'll see these kids get a growth spurt straight after their operation. So when they come back, the parents say we have to change their clothes. They've grown so much. And unfortunately, sometimes that means the septal deviation gets worse. So we do sometimes see that. So just something that we have to be aware of. All right, very briefly, we'll just talk about red flags. So the things to look out for, if they've got unilateral obstruction, anything atypical, facial pains, numbness, things like that. Unusual bleeding can be what's called a JNA, which is a vascular neoplasia in teenage boys. Facial pain and numbness, a complete loss of smell, any eye signs, sudden onset, and any previous history. So just some things to look out for that we don't ignore these issues. So the key take-home messages, again, sorry, I'm conscious of the time. Chronic nasal obstruction in kids is very common condition, potentially serious medical and social consequences. Keys to management: identify the conditions with a targeted history and exam. Start the medical management with intranasal steroids. And again, if you can't do that in your jurisdiction, ask the GP. Maintain the treatment where it's effective. If it's not, then refer for review. And if they've got significant symptoms, then refer them earlier. And the definitive intervention is curative in the vast majority of patients. Again, adenoidectomy, coblation to turbinates, and RAS tests, the majority of kids. Some need tonsillectomy if there's septal deviation, inferior turbinoplasty now, and septoplasty when older. And allergen avoidance with intranasal steroids, antihistamines, immunology review and desensitization, and myofunctional training as required. So, and then the final take-home lesson, the most important of the day. There you go. All right. Fantastic. All right.
Terrific.
How are we doing for time, guys? There's a lot of questions, but you tell me if you'd like me to go through them.
No, absolutely. Thank you so much, Professor Singh, for a wonderful presentation. I'm sure everyone here has learned a lot, and we still have over 100 people, which means everyone's still keen to hear from you, and we've got a bunch of questions. Do you have a few more minutes?
Yeah, I'd love to. Yeah.
Okay.
Yeah. And again, if anyone's had enough, then feel free to drop out. I won't be
Yes.
offended.
Yeah, we will send the recordings out. And
fantastic. So
yeah, so you just want to go through the Q&A questions.
I'll run through these. I did see there was a question before about the epiglottis, which I thought was a fantastic question. Really showed a lot of insight. So just to talk a little bit about that again, it's a bit beyond the scope of this talk, but epiglottic obstruction is something that we never thought was that big a deal, but in adults, it's a huge issue in sleep apnea. And the only reason I've found that out is in the last few years, I've routinely performed drug-induced sleep endoscopy in adults. And that has been a game changer because the literature in the past used to suggest that epiglottis obstruction was maybe 5-10% of sleep apnea, but I'd say it's probably more like about 40% where it is an issue. So again, it's something that we still treat last. We do everything else first with sleep apnea. And if you like, I can come back another day and talk about adult sleep apnea in inordinate detail. But to just answer the question that was raised, with adults, the key intervention, so in the past, we would try and stitch the epiglottis to the tongue base, which is a very fiddly operation that didn't really get great results. There was a recent publication from a group in Italy that actually used coblation to the anterior epiglottis, and that results in the epiglottis then becoming stiffer and folding forwards. And I've had very good results with that in patients with isolated epiglottic obstruction. So there are options for that condition. Now, another question we've got here. What do you think about a drug called Dupixent for allergy? So Dupixent is a biologic agent. So it's biologics is a whole other talk. And it's interesting that you should raise it because I was involved in the phase 1 studies for mepolizumab, which is another drug in that class, back in the UK in 2005 when I was doing my fellowship. And the original papers were done in Ghent in Belgium, and they really had trouble getting nasal polyps for this research. So they used to, the main researcher, Philippe Guibert, who wrote all those original papers, used to call me up. And whenever I'd have a polypectomy patient at Guy's and Tommy's in London, I'd give him a ring. He'd jump on the Eurostar with a bucket, and I'd give him a bucket full of polyps, which he'd then take back on the Eurostar to Belgium, breaching at least 3 different countries' human trafficking laws, I'm sure. But so we did. That was the phase 1 study, and then most recently, a few years ago, we did the phase 3 study for mepolizumab, and it's now routinely used for nasal polyps. And in Australia, it's actually been approved for PBS, which means the government will pay for this medication. They're very expensive medication, so typically it's 1,500 Australian dollars per month. But you'll be pleased to know, as taxpayers, our government has agreed for us to pay for those in patients with severe nasal polyposis with recurrent disease. Now, as far as the question for allergy, in general, it is not something that would be used as a first line or even second line treatment for allergy, because it is an expensive and complex medication, even though it has a great safety profile. So the first line treatments still remain allergy avoidance, intranasal steroids, antihistamines, saline rinses, desensitization, surgery. And generally, biologic agents are reserved for severe cases that do not respond to standard treatment, or if they have complex atopic disease. So, for instance, not just allergic rhinitis, but severe asthma with significant emergency department presentations, or, for instance, severe eczema to the point where they're requiring high-dose oral steroids. So hopefully that answers that question, Sandra. Next question, why have kids on intranasal steroids forever rather than addressing the problem with surgery? Isn't it a waste of time? Just go to surgery. Yeah, so that's spoken like a true surgeon. Look, surgery can help with allergy, and when it comes to allergy, there's several different symptoms that can arise. So that can include nasal obstruction, itching, sneezing, watery eyes, and general allergic symptoms. The main role for surgery in allergy is in obstruction. So by reducing the turbinate, we can improve the nasal airway, which will help with the obstructive part of their allergy. The other types of parts of allergy symptoms, so itching, sneezing, watery eyes, those are not typically addressed with surgery. And that's one of the reasons why we do address it with medical management as well. And again, it is medical and conservative management is normally the first line treatment because it's simple, it's effective, and it can work well. And it's only when that's ineffective or there's anatomical obstruction, that's when we'll look at surgery. So I hope that answers that question, Basil. Rabia asks, why is it controversial to do septoplasty when younger? Is it because they're still growing? That's correct, Rabia. So basically, traditionally, the conservative approach is not to address the septum in a young child, because the risk is that we can impair the growth centers in the septum, which then can lead to impact on the shape of the nose as the child grows. And they can get nasal septal deviation as they grow as well, which then needs recurrent surgery. Now, having said that, I've got some fantastic colleagues in the US who scoff at that and routinely perform septoplasty in kids and report great results. So that's why I do say it is a controversial area. In general, the majority of ENTs would err on the side of caution, but yes, there are some of our colleagues who do perform it at a younger age. Christy asks, why do kids with nasal obstruction, sleep apnea, grind their teeth? Any reason behind this? That's a great question, Christy, and it's one that eludes us to this day. There's a lot of theories as to why this may be the case, and Simon, you may want to chip in as well. one of the theories is that perhaps because there is obstruction, there is a sort of low-level brainstem response to try and open up the airway by grinding the teeth. But I've never been convinced that that's an entirely plausible explanation. Simon, would you add anything to that?
Well, it's a reflex, and one of the things yeah, there's no set, concrete, definitive answer to it. There's lots of theories behind.
Yeah, I agree. So the one thing I would say is that when we see bruxism in kids, universally it's going to be from nasal obstruction. As a tangent, in adults, we see it's typically a combination either of nasal obstruction and or stress. So with adults, that's a far just addressing the nasal airway may not be sufficient to address their obstruction, assess their treat their bruxism. But in kids, typically we clear the nasal airway, we see the bruxism by and large resolve, but not always. And there's certainly a lot of dental and orthodontic interventions that can help with that.
There is a theory about the trigeminal cardiac reflex. So that seems to be something that they're studying in Alberta, in Canada. And they seem to
Fantastic.
have
Thanks, Simon.
interesting thoughts on it.
The question from Ella, being in the office, tonsil reduction, is it okay in kids? I'm assuming you're asking about tonsillotomy, which we didn't spend much time on today. So that's a technique. So traditionally, we remove the tonsils in their entirety. There is a technique that's been around probably about 10, 15 years, which is what's called tonsillotomy. And that involves using the coblation wand, which is a similar device that we use for the nose, but it has more tissue reduction. And what that involves is basically we remove part of the tonsil, not all of the tonsil. And the supposed advantages with that is that it's potentially less painful, less bleeding. And we do preserve some tonsil tissue, which some parents who are concerned about completely removing the tonsils, that can be an option. So it's something that's sort of waxed and waned in popularity. Personally, it's not a procedure that I've particularly performed, but some of my colleagues do perform it. One of the issues is that the parents then and the GPs just get very confused because they just don't know if they think the child's had a tonsillectomy, but in actual fact, they've had a tonsillotomy, which then if the tonsil then enlarges again, they just get confused. I thought this child had a tonsillectomy. What's going on? So that's one of the reasons why I don't routinely perform it, but it is a valid literature supports its use. All right. Now the question from Saba: why do you not prefer to perform sleep studies earlier in children? It's a great question. So Saba, the reason that I don't routinely perform them in kids early on is because everything so if we exclude syndromic kids, so kids, for instance, with Down syndrome or other chromosomal abnormalities or Pierre-Robin or conditions such as that, with the majority of kids, as we've demonstrated, the causes are very clear-cut and can easily be identified from history, physical examination. And more importantly, we can treat those kids with simple intervention that is curative and definitive, and nothing further is required. That is by far the majority of children. So now to perform a sleep study in those kids, and again, it's a valid alternative, and some of our pediatric colleagues and sleep physicians will obviously take a different approach. But as an ENT, where I'm more interventional and more about getting things done, then there's no added benefit in doing that because it is not going to change my management. And on top of that, as I'm sure if you've ever seen a child wired up for a sleep study, it is a frightening experience. I mean, adults find it difficult, but imagine a 4-year-old with, wires everywhere, nasal probe, stickers all over them. It is not a pleasant experience to put a child through. So, and again, so with the vast majority of kids, we can identify the issues very easily with history and examination. We're going to perform a definitive curative intervention, and that's end of story. Nothing else needs to be done. Now, yes, if they are still snoring, at that point, we'll do a sleep study. if everything else has been excluded, so allergy, myofunctional therapy. But that is the reason why I don't routinely perform it early on. But again, you will hear different opinions on that. All right. Got a lot of thanks, which is that's very kind. So the septal swell body from Basil. Basil, that's a great question. So what I'd say is that if you look in the literature, just Google Basil's swell body or have a look in PubMed. You'll find there's about 6 papers in the literature in total on the swell body. And I know this because I've written 2 of them. All right. So it is a really explored area of interest. The septal swell body, for those who aren't aware, it's a region within the septum high up and just behind from the nasal valve that covers probably a couple of square centimeters. And it has the exact same tissue as the inferior turbinate, so vascular expansile tissue. And we've done research to demonstrate that as the inferior turbinate shrinks and contracts, the septal swell body also shrinks and contracts. And so we've also then started to, with a couple of my colleagues, again, some of the more controversial ones in the US, we've actually started, and South Korea, we've actually started to treat that, which again is it's considered fringe in mainstream ENT because most people they're not familiar with it. And so we use the same device, the coblation device, in the septal swell body. And where I will use that is in kids with septal deviation. We didn't really cover it today, but in kids with septal deviation where we can't address the septum, but we do inferior turbinoplasty, I will actually use the coblation wand on their septal swell body as well. And we do see benefit from doing that. And in adults, we'll use it if they have persistent symptoms post-septoplasty. So I won't go into much detail today, but certainly if you have a look on PubMed, you'll see some of our literature on that exact topic. Mohammed asks, does maxillary expanders have an impact on the nasal air volume? And the answer is definitely they do assist. I think we won't go into that to detail today. I'll leave that to Simon to cover it in detail during the course because there's a lot to say about that. Kate asks, if blocked nasal passages were not picked up when a child was young and has resulted in a sunken bridge of the nose and flat mid-face appearance, can anything be done when the child is now 18 years or older, especially to improve not only breathing but facial appearance? That's a great question, Kate. Yeah, and unfortunately, we do see that certainly with a lot of our adult patients. They've had missed nasal obstruction as a child. So typically with adults, what we find is that by that stage, the adenoids have largely shrunk away. So and typically they will have a septal deviation, turbinate hypertrophy, and sometimes nasal valve issues. So typically the commonest treatment we'll do is to treat any allergy in adults. We'll perform a septoplasty, we'll reduce their turbinates, and in some patients, a small number, will need to address the nasal valve as well. Now, as far as facial appearance is concerned, so obviously at that stage, the bones have fused, and so expansion of the maxilla and mandible is not as straightforward as in children. But there are options in adults, which we won't cover today. There is a lot involved. And Simon mentioned that Stanley Liu from Stanford is pioneering some of that work in adults. But certainly there is, from an ENT perspective, but there is maxillofacial options to address that as well as orthodontic options, which again, I think Simon will cover in his in the course, which I encourage everybody to do. Pam has a question. Would you still do a tonsillectomy on a child who has a Mallampati-4 and a large tongue where the tongue falls to the back of the throat during sleep? So look, certainly if they are non-syndromic child, then yes, we will perform tonsillectomy if they have large tonsils. And even in the syndromic children, typically the first line treatment will still be to remove the tonsils and then follow it up and then look at other options down the track. Where they have significant tongue-based hypertrophies, for instance, in Downs or Pierre-Robin syndrome, then that's something that my specialist pediatric ENTs will get more involved in. So we won't cover that today. It's not an area that I get involved in. Some more kind words. What are your thoughts on CPAP for the management of sleep apnea? Yeah, that's Ryan asked that. So we won't talk about CPAP in detail today, but if we do come back to talk about adults another day, we can discuss that in more detail. But in general, for kids, CPAP is an absolute last resort. We really, really, really want to avoid it in children. As you can imagine, sleep study is bad enough. Imagine strapping a mask to a child's face. So really, it's limited by and large to the syndromic kids, those with significant sleep apnea. But the vast majority of regular kids don't need CPAP. Ella's mentioned some issues there. We'll just skip over those in the interest of time. Orthodontic premolar extractions contribute to nasal obstruction, keeping the palate narrow. I'll give that a miss today, so Simon can talk about that on another day. There's a lot to say on that topic. Bruxism could be the body's natural way of saying it is not getting enough oxygen. Yeah, that's certainly right. That is what we think, but again, we don't have great evidence to support it. Lecture on adult sleep apnea. So Ella, I assume you're talking about the septal swell body, and then the last question is on polyps. Septal swell body. Yeah, so it's in general, it's not something I'd get too worried about, but it can be a factor. And then the question about polyps. So polyps in kids are extremely rare. It's generally more seen in adults. Typically, the highest frequency occurs around age 50 to 60. Affects about 1 to 2% of adults, more men than women, but can occur at earlier ages. In kids, where we'll see polyps most commonly is going to be in cystic fibrosis, which again is pretty uncommon and is usually picked up a lot earlier these days at a neonatal level. And the question about bleeding, we won't spend too much time on that, but the commonest cause of bleeding in kids is prominent vessels over the anterior septum, which we normally treat with cauterization to the septum. In cooperative kids, we can do that in the office with silver nitrate. In the less cooperative ones, we'll do it under anesthetic, under GA. And we just have to be careful because, again, in the young kids, teenage boys, they can get what's called JNA, which is a significant neoplasia. All right. So I think we should probably call it a day there. Again,
well
I think
done.
Kept
well,
everybody
thank you so much for
longer than we anticipated.
doing the extra mile for us. I'm sure everyone around the world is very appreciative. So thank you again, Professor Narinder Singh, for an enlightening presentation, and Simon, and for everyone here who's joined us for this wonderful masterclass. So any final words, Simon?
No, just a thank you for Narinder. Professor Singh, who has set aside valuable sleep time to help share his experience and his knowledge. It's an area where few ENT surgeons have the passion to help children in a way that seems to parallel what we in early intervention want to do. And just like there's not a lot of early intervention dentists, not a lot of early intervention orthodontists, there are not a lot of ear, nose, and throat surgeons who focus on sleep issues and the obstructions that can create these sleep issues. So part of building the bridge between our two disciplines is a communication method that perhaps reveals or illuminates some of the issues. One of the things that dentists are always frustrated with is, they sent the child that they're caring for to an ENT, and the ENT said, "Oh, everything's fine." And it's a dead end for them. Sometimes it's poor communication from the dentist. Sometimes it's not doing your homework. Sometimes it's not providing a big enough of a picture in your referral letter so that the ENT that you refer to has to pay attention to you. If you send them photographs, clinical photographs of enlarged tonsils, highlight on your x-rays the enlarged adenoids, if you fill out the pediatric sleep questionnaire. And if you fill out the sleep clinical records and you provide those records along with your orthodontic records, then on record, the ENT has received sufficient information for them to flag that this might be a child that has obstructive sleep breathing disorder issues. And if he dismisses it without further investigations, then he might be liable. All right. But if you just said, please take out tonsils and adenoids for this child, he'll look at it and say, well, it's my opinion, I don't need to do that. But if you provide a PSQ form that says there's 11 yeses, the sleep clinical record indicates a slew of issues of nasal obstructions, of adenoid obstructions, of enlarged tonsils, of recurrent ear infections, and you have clear image of grade 4 tonsils, Mallampati Friedman score of 4, orthodontic disturbances, adenoid facies syndrome. That's very different to please take out tonsils and adenoids. So thank you so much, Professor Singh, for helping us understand that this is not a dental issue. This is a primary care issue, a medical primary care issue. For those of you, even if you're not interested in orthodontics and early intervention orthodontics, this has nothing to do with early intervention orthodontics. This is everything to do with the health and well-being of a child that you happen to be the dentist of. Please screen for ear, nose, and throat sleep disorder breathing issues so that you can help these children seek primary care attention for conditions that usually correlate with the orthodontic concerns that we see as well. So I think that's really a time for us to wrap everything up. We've taken enough time of everyone. So thank you for your attention this evening.
Wonderful. And we'll send the recordings out if in case you wanted to rewatch everything in a few hours' time. Do email us if you don't receive it. Anyway, thanks again, Professor Singh. I will would love to have you as a guest to attend our 2-day event. It's the first time we've ever run it in Sydney in person. It's always been online, and thankfully we're able to get back to meeting people in person. So we'd love to meet you in person. If you'd like to meet, we're not sure whether you can make it or not, but do let us know and we'll let everyone know if you will be there. All right. So thank you again and good evening, everyone. If you're going to stay and learn more about our 2-day event, I'm just going to spend another few minutes to answer any of your questions. I know some of you have asked about the different ticket categories and so on, but good night, Simon, and good night, Professor Singh.
Fantastic. Thanks, Ken. And thanks, Simon, and the audience, which is absolutely wonderful, very well educated. And Ken, thanks for all of the organization. I know how much trouble it is to do this sort of an event.
Thank you. All right.
All right. Bye-bye.
Okay. All right. So thanks again to Professor Singh. If you'd like to contact him, is contact@ents.com.au. We've still got 50 people. If you're interested in the 2-day event, feel free to stay on for a few minutes. If you're not, thank you for joining us tonight, and all the best. So just quickly, I'm here to field questions in relation to the 2-day event in July. If you'd like to attend, it is an in-person event in Sydney, but we also will have a live stream ticket, so you can join via Zoom and interact via Zoom. So we'll be able to field questions from the audience at the venue and also field questions from you like we've done so tonight via the Zoom live over 2 days, Saturday and Sunday, July 29th and 30th from 8:30, 9 a.m. to 5:30 p.m. Sydney, Australia time. Once again, we have a special offer tonight. You can get $100 off our early bird ticket, so it's even cheaper than our current early bird tickets. I know it's 3 months away, but if you'd like to get started with the training, we actually offer the recordings from last year. If you get the live stream ticket, we will include all the slides and downloads and the recordings of not only the event itself, so you can revisit it, but if you want to get started straight away and don't want to wait till the end of July, you can get a live stream ticket, which includes the recordings from 2022. Last year, we did it entirely on Zoom, and obviously we could record it. And so you can get the recordings as well as attend via the live stream on Zoom in July. As a refresher, you can get the $100 discount until Sunday, so you get a little bit of time, a few more days to think about it. Check out the website, straightteethnaturally.com /live. And you can, get either a normal regular ticket. The premium ticket includes the recordings of the event and the recordings from last year. So the idea being, don't wait. Why wait till July if you're interested in early intervention, interested in learning about postural orthodontics, where my brother has hundreds of cases, literally showcasing this, lower arch expansion of over 8 millimeters in just that 9 months, and applying postural orthodontics. And the whole goal of his mission is to help transform really it's not only their teeth, but the whole posture. Everything comes down to posture. If you've been learning about the tropic premise, anything about all the tropics, etc., this is what it's all about. And then 2 days is very comprehensive, a lot of practice templates. So you literally can, right after the event, order appliances from Enrico, who developed these appliances over 12, 13 years with Simon. And you can not only order them, but have Dr. Wong design your first few appliances until you get the hang of it. We do cover it in the training, but some people have asked about whether Simon can actually design the appliances, which he can do for a fee, of course, working closely with Enrico. So if you've already graduated from our 2-day event from last year, or feel free to email us about the details regarding the Wong design. If you've completed the 2-day intro, want to learn about our advanced program, there's additional training and mentoring where Simon, literally every 2 weeks, you can submit your photos, x-rays, Ceph analysis, notes in a PowerPoint. Simon will give written feedback, and every 2 weeks, he spends 3-4 hours answering questions and going through the presentations in a very small group, generally under 10 people. So everyone can get hot seated, and we have a couple of different times during that weekend every 2 weeks. So we cater for the European time zone, cater for Asia, Australia. So there's generally a good time for everyone to join in. So that's a 12-month mentoring program. You can trial it out for 3 months. Every 2 weeks, you get to spend 3-4 hours with Simon, so he can supervise and mentor your individual cases. So that is by application. It's only for 2-day graduates. straightteethnaturally.com /application if you want to learn about that. But the main event once a year that we run is going to be in Sydney, Australia. But we're going to give $100 off for those who have the patience to stay on and learn more about it. But if you have any questions, I'm here to field some questions. If you want to attend but have some questions regarding the 2-day event, I'll stay for a few more minutes. Otherwise, thank you for joining tonight. I hope you learned a few things about nasal obstruction. I certainly did. So, all right. Any questions? Let's take a look here. Please guide me regarding this issue. Dr. Jawad, yes. If you had, we have very limitations in Afghanistan. Okay, understand. So that's why we have the live stream ticket. You don't have to physically fly to Sydney. We have people coming from Iraq, all around the world. But for those who cannot attend in person, we have a live stream ticket. So you can watch the entire 2-day event from the comfort of your home. If you've been watching this from the comfort of your home, then you can join our 2-day event to learn about early intervention, right? So so I want my son's treatment. Well, if you want to get Dr. Wong to guide you on a lot of people who join our mentoring program often have their first case or two as their family members, because there's obviously that's something that's often pressing and very, very important. So if you have a child between the ages of 3 and 9 or 10, ideally 8 and younger, for postural orthodontics treatments, where Dr. Wong can help you with the expansion and guide you through it every couple of weeks over a period of time, then first step will be to join our 2-day intro program. Go through that first. Then if you want to learn more about the advanced program and the mentoring program, that's after the 2-day event. Makes sense? So he's only 5 years old, severe bruxism occlusion. I'm not a dentist. My brother, Dr. Simon Wong, is, and I'm sure you have all these questions that you can bring up. Actually, once you finish the 2-day intro, the application is for the mentoring and training program, for the advanced program, is designed for you to a lot of people have a lot of questions. What about this instance? Will you mentor me on this, etc.? So that's where you get a chance to speak to Simon one-on-one for a short 15-20-minute call to see whether he can help you in the mentoring program. All right. Now, there's sometimes going to be cases that are very severe malocclusions, and that requires orthotropic type of treatment that could take 4 or 5 years of treatment. And right now, Simon is generally not mentoring folks on the super advanced stuff. We want to start step by step by helping the folks with cases that are more mild malocclusions, because that's where you should start. The complicated cases, by definition, are complicated, take years. When Simon will showcase some of his work, he's treated some children from the ages of 4 to 9 to 10, 11. It takes many years sometimes to get, the way that he wants the outcome to be, right? But if you're looking to learn about his postural orthodontic methodology, which is, different from orthotropics, which is more complicated, treatment that takes many years to complete the treatment, many years of supervision. If you want to go down that track, we've decided to start with postural orthodontics. Once again, best to get on an application call. It's obligation free, no cost, but you can only do that after you complete the 2-day intro. Does that make sense, Dr. Alwood? So it's, I won't be able to, yes. So it's best, once again, he doesn't do any online consultations. All right. A lot of people are sending us emails with photos and details and asking Simon whether he can give any feedback. The problem with that is that we are getting dozens of people doing that, and he cannot just give a quick, free consultation or even a paid consultation, because ultimately, unless he's here to supervise it, he can't really give meaningful advice, because every child is very different. And during his mentoring program, which is ideally at least a year long, because we're teaching postural orthodontics techniques that take about 9 to 12 months to complete. So he can guide you through that. Every 2 weeks, you're submitting updated cases to him from photos, self analysis, and so on and so forth. And he's giving one-on-one personal feedback in a written format, and in a group setting, in a small group. We've got a half a dozen people right now in our mentoring program, where the group can, individuals will be hot seated for 20, 30 minutes each. You've got the PowerPoints, you've got the photos, everyone can see it. Everyone can hear the feedback that may be relevant, not only to the individual being hot seated for their particular case, but also for all students who are listening in. So it's a wonderful way to learn in a small mastermind group setting. But once again, just be aware that Simon does not do online consultations. We get asked that a lot, right? So you do need to do, the only way you can get a free consultation, so to speak, is to complete the 2-day intro, apply for our advanced program, which only graduates can do. Then he'll jump on a call with you to see whether he can be of help, whether his mentoring program will be suitable. Because once again, he won't mentor at this stage very complicated cases because they take many, many, many years to complete. So we're going to roll that out only for people once they've completed at least a year or so of the phase 4, the mentoring program for postural orthodontics. Anyway, so do send us questions. Feel free to email us regardless if you've got questions. But the first step will be to join our 2-day intro to postural orthodontics. Email us at info@straightteethnaturally.com, subject $100 off. So we can give a discount for joining us tonight. Once again, the ticket prices, there's 3 different categories of ticket. If you just want to join us via live stream on Zoom, it's $1,097. We can split it up into 3 payments. So just email us for the details. All you gotta do is email us, tell us which category you're interested in. We'll give you the discounted pricing options with the payment plan options, and we'll send you an invoice. You cannot order this and purchase this on our website. We haven't catered for all the different combinations and the discounts. This is just a last minute thing we've put together. So if you want the $100 discount for staying all the way till the end of this presentation, for those watching the recordings, this offer is valid until the end of this Sunday. It is Wednesday morning New York time here. So 4 or 5 days to check your calendar. If you go to the website, actually, you'll see whether in fact, we have a preview webinar as well. So you can check out all the information on our website, straightteethnaturally.com. I'll type it in here. It's already put on. We've already put the details already. That's the website, but if you want the discount, then you need to email us. All right, so I'll just put it one more time for everyone. All right, any questions regarding the event? Otherwise, we will wrap up. There's still 20 odd people, so either you have a couple of questions or yeah. So any final questions regarding the 2-day seminar in July? All right. Any other final questions? Let's see. Sandra, okay. Sandra wants to know about getting the recordings of the event. Yes, you will. We will email everyone the recordings of tonight's event. Takes a little while for Zoom to process, and then we'll just send the link out to everyone. So maybe in a few hours. So we'll just make sure that you will get the recordings as well. Just double check your email is in the system. That's about it. All right. Well, thank you very much for joining tonight. All the best. And we hopefully will see you in July. Take care. Bye-bye.